So thank you all for coming to the presentation today about effective diagnosis and treatment of premenstrual dysphoric disorder, which I'll refer to as PMDD for the rest of the slides. Can everyone see the slides okay, I'm assuming? Okay. So just an overview of what we'll be talking about today. So we're going to do kind of a quick intro on what PMDD is, talk a little bit about how to make an accurate diagnosis, go into prevalence and risk factors, some history of where this diagnosis came from and how it got into the DSM and the place that it is today. We'll go over the etiology, current understanding of the pathophysiology of PMDD, and then some population differences in women with and without. And then to kind of bring this material to life a little bit, I'd like to talk about case notes of what the experiences that women have with PMDD look like and how they describe that in their own words. And then the last part of this, we'll talk about treatment. So I'll be covering the behavioral health side of things, and then Dr. Kerr will take over for the psychiatric. And we'll open it up to questions at the end. Okay. So just some background on what is PMDD. So it's a complex, often disabling mood disorder that affects women of reproductive age, characterized by severe physical, psychological, and behavioral symptoms that occur cyclically and then remit following the onset of menses. So the criteria are the cyclic nature and then the inclusion of psychological, behavioral, and physical symptoms. So it's currently listed in the DSM-5 under the depressive disorders section. And I just wanted to note that it is different from premenstrual syndrome. So the two terms, PMDD, PMS, are kind of used interchangeably at times, especially in popular culture, but they have different etiology, and PMDD is a distinct clinical entity with different treatment as well. It's the only form of premenstrual disorder that's in the DSM-5. And so just something to consider when we are talking about PMDD, that we're just talking about something distinct from premenstrual syndrome. Okay, so for the DSM criteria, so there's a cluster of 5 or more symptoms that need to be present in this cyclic manner. So present during the majority of menstrual cycles, symptoms present themselves within the luteal phase, and then we see remission or absence of symptoms after the onset of menses. So within that cluster of five symptoms, one of them has to be affective symptom. So either marked depressed mood, anxiety or tension, affective lability, so sudden tearfulness, sensitivity, repression, or anger and dysregulation in that regard. So in addition to one of those principal affective symptoms, you can have a cluster of other symptoms that add up to the 5 total. So additional symptoms might include decreased interest in usual activities, concentration difficulties, lethargy, fatigability, differences in appetite or specific food cravings, sleep disturbance, the subjective sense of being overwhelmed or out of control. And then some common physical symptoms might be joint or muscle pain, breast tenderness, bloating, and weight gain. So that's kind of the cluster of symptoms adding up to 5 or more. And then, of course, symptoms need to cause clinically significant distress or interfere with work, social activities, or relationships. Okay. So when making a diagnosis, just some things I want to make sure to touch on. So with the affective symptoms, they are, so there's a lot of, there's high prevalence of maybe anxiety, depression, mood lability. With that comes a high likelihood of this diagnosis of like anxiety disorders, depressions, bipolar disorders, and even sometimes personality disorders. So for providers, one thing that's really important to think about is, do these symptoms fall into kind of this cyclic occurrence? So is there the presence of the symptoms during that luteal phase, and are you seeing a remission or an absence of symptoms during the other part of the cycle? So it's not simply an exacerbation of depression around, predominant most days of the cycle and then get during the luteal phase. We're seeing that instead it's this pattern of, pretty intense, severe, debilitating symptoms during that luteal phase, at remission and absence the rest of the time. So in order to make the diagnosis according to the DSM, you need ratings from 2 prospective cycles. So when someone comes in, they're complaining of symptoms and you think, oh, this appears to meet criteria or looks like the picture of PMDD, the DSM says give a provisional diagnosis of PMDD at that time, and then you're going to need ratings from 2 symptomatic prospective cycles in order to confirm diagnosis. Last thing on the slide is just, it's not a clinical term, but something I call the blue skies phenomenon. And it's something that I've experienced in working with these women is that due to the cyclic nature of the disorder, often people are treatment seeking when they're in kind of the height of that luteal phase, when they're having these affective challenges and intense, disruption in relationships. So they're calling for appointments. And by the time they get in a week later, maybe 2 weeks later, affectively they're fine. They present, totally normal, euthymic. And so there can be a lot of confusion and a lot of misdiagnosis that goes into that presentation. And so that's just something to kind of look for when you're meeting with women and they're maybe disclosing this amorphous timeline of symptoms, but they're totally fine now, is to look into the cyclic nature, see if does it follow this pattern, so that we're not missing that. Okay. So touching on prevalence and risk. So prevalence, the DSM quotes around 2 to 6% of menstruating women meet criteria for PMDD. More recent estimates are circulating around 3 to 8%. I wanted to go a little more conservative, but we're probably looking around 3 to 8% these days. I looked at a meta-analysis on studies concerning risk in this clinical group. So looking at studies of suicidal ideation, suicide plans, death by suicide, and the conclusion of this meta-analysis is that women with PMDD should be considered a high-risk group for suicidality. One of the statistics that I pulled from that, so in terms of lifetime creation of a suicide plan, the general population of women without PMDD, it's about 4%. Women will create a plan for suicide throughout the course of their lives, at least one. With PMDD, it's 4 to 5 times that rate. So we're looking at a condition, a diagnosis that places someone in this high risk category and would be considered on the provider end as well. Okay. So just some history of PMDD. I know there's a lot of kind of confusion in lay culture about what is PMDD, how did we come to this understanding, is it PMS? And so I think it's helpful to kind of go through the timeline to see how we got to the point where we are now. So in 1931, Robert Frank, we have the first modern research on PMDD. So he had observed in 15 women this kind of cycle, this phenomenon of mood-related symptoms that appeared tied to the menstrual cycle, and he coined the term premenstrual tension. Later in the 1950s, the term premenstrual tension was replaced with PMS. In the 1980s, in the DSM-3, we see the first emergence of what they had termed at the time late luteal phase dysphoric disorder. And then fast forward to the 1990s, that late luteal phase dysphoric disorder was termed premenstrual dysphoric disorder, or PMDD, and it was included in the appendix, not the main body of the DSM text. I'll talk more about that in a second. And then 2013 finally moved it into the body of the DSM under depressive disorders. And then most recently, I think is a pretty exciting change, is that the World Health Organization just announced inclusion of PMDD in the ICD-11 as a medical disease of the genitourinary system. And so it is now officially characterized as both a psychiatric condition and a medical condition, which is a move that they hoped would help spread awareness, increase access to treatment, both through the medical and the psychiatric side, and also which acknowledges kind of the complex etiology that is both physiological, emotional, as well. So part of the reason I put up that timeline is just so that we could see that the modern research started around 1931. And DSM wasn't included, or I'm sorry, PMDD wasn't included in the DSM in its own separate category or its separate classification until 2013. So why did it take nearly 100 years for this to happen? And one of the commonly cited criticisms or controversies is that there is a lot of discussion, a lot of debate around these fears of women being pathologized or having the menstrual cycle be, part of a natural feature of woman's life that is then medicalized. And the DSM-4 work group actually discussed that its inclusion in the appendix rather than the main body of the DSM was not related to the level of evidence. There was substantiating evidence to confirm it as a diagnosis in the main body, but they were more concerned about the potential stigma that it could cause women. Ultimately, they concluded that the kind of outweighing the pros and cons that we need to have this diagnosis included in the DSM so that we can have research, treatment, opportunities, and awareness open up because women are experiencing debilitating symptoms and that professional biases really are not they're well intended, but the limitations that it's placed for this disorder as far outweigh the benefits that we see. Just a quick anecdote. So when I was in graduate school, part of the reason I got interested in PMDD is because in my psychopathology class, my teacher during the DSM depressive disorders section put PMDD on the PowerPoint slide, pulled up the depressive disorders, and then said, yeah, so this disorder is in the DSM, but it's pretty sexist, so we're not really going to talk about it. And she just moved on. And so you had this entire cohort of students who that was their first exposure to PMDD, is hearing that it's sexist, that it's not real, and it shouldn't be in the DSM. And then my teacher moved on. And so it led me to do research on, well, is that actually the case? And what I found overwhelmingly was that the etiology the research is very strong on this disorder being real, having physiological and neurological components to it, and then really having a lot of debilitating results for the people who live with this. So part of my task here is spreading awareness on that and also challenging providers to kind of check their own biases on how they feel about this disorder and weigh that with what you see in the literature. Okay, so in discussing etiology, I'm going to go over an overview of kind of where we stand right now with our understanding and then touch on a couple additional findings related to brain imaging and cognitive sets. Okay. So due to the kind of cyclic timing of the menstrual cycle with symptom on and offset, we know that that hormonal fluctuation is a key component of pathogenesis. Initially, it was thought that women with PMDD, maybe have a hormonal imbalance. They're differing levels of ovarian hormones, and that actually doesn't bear out at all in the literature. So women with PMDD cannot be distinguished from asymptomatic women in terms of ovarian hormone levels. Instead, what we're finding is this hypothesis of dysregulated sensitivity to normal hormonal fluctuations throughout the cycle. So women with PMDD to have altered sensitivity to fluctuations, especially of estrogen and progesterone. And sensitivity is at the receptor level. So for allopregnanolone or allo, this is a metabolite of progesterone, and it attaches to the GABA A receptors it's an positive allostatic moderator, much like a benzodiazepine or alcohol that typically produces a sedative effect. And in women with PMDD, what we see is a suboptimal reactivity to allo. And so it's hypothesized that those hallmark symptoms of anxiety, depression are somehow related to that functioning of allo at the receptor site. Another implicated neuroactive steroid hormone is estradiol. And so we know that there are connections between estradiol and serotonin functioning that are involved in, modulating mood, sleep, eating behavior, other behaviors that are implicated in PMDD. Additionally, women with PMDD exhibit specific serotonin abnormalities that are particularly apparent in the late luteal phase when estrogen levels have declined. So these include, several things, but especially deficiency in whole blood 5-HT levels. So kind of the take-home message for this is that we're not seeing imbalance of hormones for women with PMDD. We're seeing this decreased sensitivity to normal hormonal fluctuations at the receptor level. The second piece of this is genetic factors. So twin and family studies show a 30 to 80% heritability. And there's also research involving gene coding that shows differences in coding of the serotonergic 5-HT1A receptor, and then the differing roles of allelic variants for estrogen receptor alpha gene ESR1. So the research is less robust right now on those genetic factors, but we know that there's some link there that's contributing to development. And then the last piece of this is a history of significant stress exposure. So we've had several replicated studies of cross-sectional studies of thousands of women that show an association between stress exposure, trauma exposure, and development of PMDD. And etiology is not, or I'm sorry, the mechanism behind that is not yet clear, but it's believed to be some irregular functioning of the HPA axis, and especially in connection of the HPA axis and the HPG axis. So these are kind of the main pieces that we're seeing right now in women with PMDD. Just some additional, more recent findings. So we don't yet have a ton of research from the neuroimaging side, but what we're seeing when we are reviewing those studies, so this is a review of what we have as of 2020, is a differing corticolimbic activation in response to emotional stimuli. So during that luteal phase, you have increased reactivity of the amygdala and the insula for processing negative emotional material, and then you have a decrease, an impairment of top-down inhibitory processes from the frontocortical function. So you've got increased processing sensitivity to negative emotional stimuli paired with a decreased inhibitory response, which is believed to imply reduced cognitive control over emotions and negative mood symptoms. And then in terms of cognitive studies of negative bias, so we know that depressed patients show these common kind of mood congruent errors in identifying emotion in facial expressions. And so these researchers did a study where they took women at different times of their cycle, both women with and without PMDD. They showed them nonverbal affective information, faces, and they found that the errors are consistent. The negative judgment, negative bias is consistent during only the luteal phase specific time for women with PMDD, and it looks like that of those of depressed patients. And we're not seeing the same cyclic variation in women without PMDD, even during the luteal cycle. So there is evidence of a negative bias that's phase dependent for women with PMDD. Okay. So to kind of bring this to life a little bit, I wanted to talk about specific women that I've worked with and what their experiences have looked like, how they describe their symptoms, and then talk a little bit about what the qualitative research shows for women who are living with PMDD. So I've worked with a handful of women. I just pulled these two cases because I thought their profiles were pretty distinct and interesting. So the first woman was a 27-year-old Puerto Rican cisgender married female. She actually came to me with a diagnosis of anxiety, which we found out to be PMDD, but she described debilitating mood episodes that would occur cyclically, involved uncontrollable crying, irrational thought streams where she was having these paranoid thoughts about her partner cheating her when they were in a very stable and trusting relationship, and then she'd have some difficulty breathing. And so these episodes were really impairing to her relationship. And when she was not kind of in the midst of these episodes, the rest, she was functioning well. She was in a loving relationship. And so like kind of seeking help and seeking understanding. And I think getting a diagnosis for her and learning tracking and kind of clear established behaviors that she could use to self-manage these symptoms was key for her. The second case here is a 25-year-old white cisgender female, and her predominant affective symptom and complaint was aggression and loss of control. So she was actually in an all-women, all-female metal band, and during the time that she was experiencing these luteal phase symptoms, she described getting so out of control, so angry, she had like smashed guitars and was almost like ruining their shows, and it was causing really intense interpersonal conflict in her relationships. I mentioned bloating here is because she experienced such severe bloating that the difference between when I would see her in the luteal phase, like observe her in the luteal phase versus maybe a session 2 weeks later, she had lost 10 pounds. So very, very significant observable level of bloating there. Alcohol was a trigger for her, even further decreased that inhibition for her behaviors. And then she experienced some improved control with exercise. Some things that I hear over and over working with women with PMDD is kind of this sense that a demon is taking over or you feel possessed. It's such a different experience from how you feel in your own body, how you're responding to the world throughout the different times of your life. Things that I hear that I haven't heard really associated with other disorders are what people have called self-deprecation attacks. So these acute periods of very intense self-deprecation thoughts and feeling completely worthless, and they don't accord with how women feel the other times of the cycle. So it's just these really acute periods that are often associated with suicidal urges, and again, show up just during this luteal phase, and then the rest of the time, they're not suicidal in any way, shape, or form. And so I'll talk a little bit more in treatment about how to handle those differences. So this was a qualitative study that was done with women who were diagnosed with PMDD, talking about their experiences. And some key themes I just wanted to touch on because I found them quite impactful. So for the first theme of a broken woman, these women described difficulties coping with psychological distress. And I quote, "When I say I feel down, it's not like just feeling down. It's feeling like your whole body is numb. Like I've had so many times where I felt like if I put my hand through a wall, I'd go straight through it. Like that's the level of sadness." Often these women used words such as monster or alter ego to describe the psychological change that had them experiencing feelings like they transformed into a different person, someone they didn't even recognize as themselves. And again, that's something I've heard time and time with the women I've worked with. Second theme was misdiagnosis and lost decades. So many of them described getting a variety of diagnoses from healthcare professionals, so anxiety, depression, bipolar disorder, personality disorders, and then concurrently being prescribed a variety of psychiatric meds that didn't treat their symptoms that they were on for many years. And then another kind of sub-theme was being negatively appraised by healthcare professionals. So being seen as faking or exaggerating their symptoms, and how that kind of further impacted their sense of self. So the third theme related to the impact that finally getting diagnosis had on self-identity in their lives. Most women talked about feelings of immense at the realization that their experiences with symptoms suddenly made sense. And that was in contrast to those previous misdiagnoses where they felt like this finally captured what they were experiencing, and it was a huge relief for them. And the last piece was negotiating the aftermath. There was this sense of how treatment and diagnosis was transformative for their lives, but still this overwhelming grief of how long they had lived with PMDD, how it had impacted their ability to maintain jobs, to maintain relationships, and having to kind of struggle to come to terms with this, what they called kind of like a fractured life and moving on. Another thing I just wanted to touch on that was mentioned a few times was the continuation of the feeling of being stigmatized or misunderstood, especially by people within the medical community. One woman said there was a medical doctor she saw who said there was no such thing as PMDD, no such thing as PMS, that this is just something women say. Okay. So moving on to treatment. going to go over the behavioral health side, and then Dr. Kerr will take over for psychotherapeutic. Okay. Oops. Okay. So the first place I start when I'm suspecting a PMDD diagnosis is just with psychoeducation. As we've said time and time again, the awareness level within the medical community and within the is still kind of lacking. So empowering women to research their experiences and kind of some increased understanding of themselves in that process. Tracking is another thing. Every single woman I work with who is open to it, hopefully they are, I encourage tracking just so they have that kind of feedback loop. They have a sense of when to expect these symptoms and can kind of use that as a guide for themselves over time to learn about their pattern and to then create a personal profile of what is their pattern of symptoms, when do they onset, when do they remit, so that there's that enhanced understanding. Stress management, I won't harp too much on just the importance. We know that this is that there are to stress, there's enhanced stress response and decreased inhibition or modulation of those negative emotions. And so coming up with a unique stress management plan that works for the person is very important. Social support. So along with tracking, often if someone has close social supports in their lives, getting them involved in treatment. We know that PMDD tends to have very intense negative impacts on relationships. And so if you're able to involve a partner, a friend, family member in helping you to identify when you're not yourself, or, I've even had partners put little timer reminders in their own phone so that they're more prepared emotionally during these times when the individual might struggle more with emotional regulation and those kind of symptoms. Community just refers to there being a wealth of support groups and more emerging every day. Many of them are online that people can get connected to. So on the psychological side, so cognitive therapy has been the most studied and it shows efficacy for managing symptoms of PMDD. Some of the most important findings from that relate to how cognitive therapy can help with self-compassion and self-understanding. So being able to not internalize the experience of these intense emotions as, I'm a bad person, but being able to create some compassionate distance of this is happening with me. I have skills to manage this and I can, get further help. So kind of creating that distance has helped. And then obviously safety planning, as we know, this is a high risk population. Okay, with that, I'm going to turn it over to Dr.
Okay. I am going to talk briefly about some pharmacologic treatments that we can use in treating premenstrual dysphoric disorder, PMDD. I'm going to use from now on as well. When we're looking at treatment, our goal is going to be relieving the premenstrual affective and the somatic symptoms. So if you remember when Olivia was discussing the DSM criteria, we have both kind of affective, anxiety symptoms, and also physical symptoms. And the daily rate of severity of problems, or the DRSP, is a tool that's available in the public domain. This is a picture of it, but I know it's kind of hard to read. And it just has ratings for 11 major symptoms, including like feeling depressed and sad, having mood swings, feeling anxious or on edge, difficulty concentrating, sleep difficulties, and then a question about kind of physical symptoms in general. So breast tenderness, swelling, bloated sensation. And then the 3 questions at the end ask about kind of functioning. So is it impacting your ability to be functioning well at work and at home? Is it causing you to have, or the patient to have avoidant tendencies? And is it impacting relationships with others? And this tool is really helpful, not just in measuring efficacy of treatment, but it actually can be a tool that you use when you're trying to establish that diagnosis, taking it from provisional to a solid diagnosis. We can use this. Usually you track it for a month at a time, and you have, not only do they rate their symptoms from 1 to 6, but they also indicate on this form when they were menstruating, when they were having spotting, so that you can really establish that luteal phase and cyclic nature of the symptoms. So a lot of the studies that we use to look at efficacy of treatments are going to use the DSRP as their kind of outcome measures. What are symptoms on the DRSP decreasing? So before I talk about specific medications, I just go over some considerations that we should have when we're choosing from the various medication options. We should definitely be looking at kind of severity of symptoms. Can we get away with more of the behavioral or psychologic treatments before going to a pharmacological treatment? Response to any previous treatments is important to consider. So contraceptive needs, is your patient wanting contraception? That might point you to a certain class of medications. Or if they are on the converse side, are they planning to conceive in the near future? And that might dictate which medication route you're going to go. And then just things like treatment modality preferences. Do they prefer to be on medication for a shorter period of time? Do they want to do, injections versus pills, things like that. So the first category, I stole this or borrowed this figure from a review article by Lanza D'Scalia, and I thought it was a really nice, succinct way to show all of the different pharmacological treatments, and some of them are supplements that we have studies for demonstrating their efficacy. So for PMDD, the first line treatment is going to be an SSRI. And generally with SSRIs, we use the same doses that we do for major depressive disorder. And interesting, you may note that fluoxetine, sertraline, and paroxetine all have FDA approval for the treatment of PMDD. There are a couple other antidepressants that have been studied but haven't gotten that full FDA approval. It doesn't mean you can't use them. They have been shown to be efficacious. They just, it would be an off-label prescription. So a couple antidepressants that have been studied that aren't SSRIs would be venlafaxine and clomipramine. And those both have shown efficacy over placebo in trials, but when they've done trials comparing SSRIs to venlafaxine or non-serotonergic antidepressants and then placebo, the SSRIs outperform the non-serotonergic antidepressants, which is kind of why they are our first line in this category. Sorry. Thank you. So when we're looking at the dosing, I talked about the dose as far as kind of per the pill dose, but the other thing to consider is when the doses are given. So with our patients that have major depressive disorder, we're going to tell them to do continuous dosing, take it every day, about the same time, don't miss a dose or it decreases the efficacy. That's not actually the case necessarily with treating PMDD. You can do continuous dosing, but there's been studies that actually show that intermittent dosing, which is also called luteal phase dosing, where you only take the medication during the 14 days before you start menses, or symptom onset dosing, which is actually where you don't even start taking the medicine until the first onset of symptoms, and then you stop it when your period begins. So the intermittent dosing and the symptom onset dosing have both been shown to be efficacious, as well as the continuous dosing. In some studies comparing the various forms that show that continuous and intermittent are equally efficacious. And then there are a couple that show that maybe there's slightly decreased efficacy in the intermittent dosing. And specifically what I saw is that physical symptoms may respond better with continuous dosing than intermittent dosing. So if you have a patient that's really experiencing a lot of physical symptoms, you may want to consider the continuous dosing rather than the intermittent or symptom onset. Another thing when we're comparing like how we would use SSRIs for major depressive disorder, we usually really encourage our patients not to abruptly stop taking their SSRIs because they may have discontinuation syndrome. However, so you might think, why would I tell my patients to do intermittent dosing? They may have discontinuation syndrome when they are only taking it for 14 days and then stopping it. But actually, they've done studies that show that there's not really an association of discontinuation syndrome with intermittent dosing. And we think that's just because they're on it for such a brief period of time that it hasn't allowed for the downregulation of postsynaptic receptors that we link with discontinuation syndrome. So you might consider intermittent or symptom onset dosing if you have a patient that's trying to conceive in the near future and you want to decrease their exposure to antidepressants, or if they have medication tolerability issues. So they're just on the medication for less time. The next big kind of class of pharmacological treatments options would be options that are suppressing ovulation. So oral contraceptives have been prescribed by clinicians for PMS and PMDD for quite a while, but until recently we hadn't done a lot of literature on it, and probably was because of as Olivia alluded to, kind of getting PMDD to have kind of an established diagnosis in the DSM. But the studies that we are doing now are showing that drospirenone-containing OCP are more effective than placebo in decreasing PMDD symptoms. And because of that, Yaz, which is a drospirenone-containing oral contraceptive, has been FDA approved for treatment of PMDD in patients who desire contraception. So this would be a good option for maybe an adolescent teenage patient who's having PMDD that you don't want to be getting pregnant. This is going to give you contraception and treatment for PMDD. When you're considering oral contraceptives, though, you do need to evaluate for the risk of venous thromboembolism, because there is a slightly higher risk. And so you just need to make sure you're considering that if you're going to go this route. But again, these are going to be fine after your SSRIs. So if you're not needing the contraception piece, I would recommend, generally the SSRIs are going to be your first choice. Another option in this category would be a GnRH agonist, or leuprolide injections is the most common one. And so basically what these do is downregulate your GnRH receptors, which then will decrease the amount of FSH and LH that's being released from the pituitary. And so as a result, you'll have decreased estrogen and progesterone levels. And so there have been studies that show that this is an efficacious treatment. However, the side effects or kind of the risks of a prolonged anovulatory state is something you have to consider in these. So when you aren't ovulating, you're going to have hypoestrogenergic. You're going to be in a prolonged hypoestrogenergic state, which leads to risks for decreased bone density, kind of cardiac effects. So there have been studies about doing kind of add back of these hormones. It's a little bit out of the scope of this talk that I have time for today, but that's a reason why this is really kind of the third line. I've tried SSRIs, I've tried OCPs, and I'm not getting anywhere. This would kind of be something I tried last. And then in Europe, they use transdermal estrogen a lot and have some studies showing efficacy with that. But you're going to have the same kind of long-term issues with that as you will with the GnRH agonist. So another reason to kind of save those for last resort. And then some other treatments that I'm briefly going to go over, mainly the calcium as a dietary supplement. So the studies have been with 600 milligrams twice a day. This might be a good choice for somebody who doesn't want to be on a prescription medication because it has been shown to be efficacious compared to placebo for the treatment of PMDD. But when they compare it with fluoxetine or even OCPs with drospirenone, it is not quite as efficacious as those two. So it's still not going to be your first line, but if you have somebody who is still really struggling but doesn't want to be on a prescription medication, that's a good option. There's been some mixed findings using essential fatty acids or vitamin E, magnesium, and then there's some preliminary reports with vitamin D, tryptophan, or fish oil, but they're still kind of in the preliminary stages of studying those. And then a kind of complementary treatment that's been studied mostly in PMS, but I think there are some use in PMDD is chasteberry. I'm sure I'm saying that wrong, but that's just an herbal treatment that has been shown to be some efficacious. But again, it's going to be efficacious compared to placebo, but it has mixed results when they compare it with fluoxetine. So again, your SSRIs are just going to be your first choice really in this treatment algorithm. And so I'm going to pass it back to Olivia and let her kind of wrap up.
Okay. So before I go over summary and Q&A, I actually just wanted to quickly pop up a slide with some resources for people. So I talked a lot about cycle tracking. So there's the DSRP form that they can use, but also just on a more day-to-day basis, there are free apps that you can get on your phone, such as Glow or Me versus PMDD. They're easy for just kind of keeping up with your cycle. Some online support groups, there are so many of them, but there's one for moms, there's one for teens, they're free, and then Vicious Cycle, a popular support group that's on Instagram for younger women. And then for psychoeducation for patients, there's a link there to the IamPMDD.org website, and then there's also a link for provider resources. So it's going to be information on diagnosing, some studies. You can find the forms like the P form through that. So just some resources to look into. Okay. That, fire away with the questions.
All righty, we have a couple of them. So first question we have is, let me back up here to the top. Just want to make sure I have the right one. What is the average age in young women who are diagnosed with PMDD?
I actually don't know the exact, age of onset, but I do know that symptoms are going to be, can be present from as early as, first menstrual cycle to when women start going through menopause. So there's availability for symptom presentation through that entire menstrual, phase of life. But I don't remember off the top of my head.
Yeah, I don't either.
All righty. Next question. Would we use continuous dosing if the patient had abnormal cycles?
Oh, that's actually a good question. I didn't see in when I was researching for this study or this presentation, I didn't see anything specifically, but I would say probably if you're having because it needs to be in that luteal phase. So I would probably either go with the symptom onset dosing if you can kind of do it on the symptom, but if it's several months in between, I might just consider continuous dosing because it's going to be hard to track and know when to start if you don't have regular cycles.
All right, let me see if there are any new questions that have come in. Encourage attendees to ask questions in the chat, and I will share those with our presenters. There have been questions about obviously obtaining the recording, and we cannot do that at this time. We are in the process of working with our CME department to make that happen. But if an attendee has questions, can you make available to us a list of your resources so they can receive that?
I mean, we have in the slides, I don't know if those are going to be given out. We do have our references.
Okay.
I put them up just now too. I don't know if people can write them down quickly, but they're in our
Absolutely. Terrific. And if anybody would like to have a copy of this PowerPoint, please just email cpaninfo@uthct.edu and we'll get that sent out to you quickly. So a couple of questions have just come in. Do you see as much problem with decreased libido with the SSRIs?
So that was not, I didn't run across that in my research for this. I think it may be possibly, it's going to be an issue, that's a known side effect of SSRIs. So I think if you're doing continuous dosing, that may, it's still going to kind of be a consideration. I don't know for sure, but I might think that doing the intermittent or symptom onset dosing might help with that, having it be kind of less exposure time. But I didn't see that specifically addressed in the studies that I researched.
Thank you, Dr. Kerr. Another question, what was the third point on the etiology slide, please? We've got people making some notes. If we could go back to that one.
Sure. So I think it was significant stress exposure. Let me pull that up. Oop.
Uh-oh.
Uh-oh.
We lost it. Okay.
Sorry, my slides disappeared for a sec.
No problem.
No, they're gone. Okay.
Goes back. Yeah, that's good.
While we're looking for that one, I'll ask another question. Oh, looks like you found it. Okay.
So was it the significant stress exposure piece, I imagine? Yeah, so that meaning that there's a significant association between stress exposure and life, significant stress exposure, whether that's ACEs or later experiences of trauma, physical, emotional, and to a lesser degree sexual, and PMDD diagnosis.
Thank you.
You're welcome.
All right, excellent. Another question. Any suggestions for overcoming providers' reluctance to take this as a serious possibility in patient diagnosis?
think, yeah, it's definitely something to be aware of. And like I said, there's been a long history of this, some of it well-intended. But I think the role that we play as providers is just to look at the etiology, look at the information and the research that's there, and just kind of continue to spread that awareness. I think that's kind of the best that we can do is by example in that way, and kind of refer people in not obnoxious ways to like the studies of here's the etiology, it's not hormonal imbalance, it's this, decreased sensitivity to these neuroactive steroid hormones, and we see neurological differences, we see differences in of neurochemicals, and so there is a very real aspect to this disorder that I think will come to light in time, but it's kind of slow going.
The question, do you recommend counseling and or therapy along with the hormonal therapy?
I mean, I think that cognitive behavioral therapy has been shown to be helpful for this. So absolutely, I think that would be a consideration.
Yeah, so right now, we're not really distinguishing in the DSM from like mild, moderate, severe. So there is a wide range of presentations and, the extent to which this condition is debilitating for women. When I was working with women on PMDD, it was mostly in like a behavioral health consultant context. And I actually found pretty impactful results with just the awareness piece is kind of one of the most critical things. Is just knowledge of what's happening and the ability to self-manage symptoms with tracking and with, support people in your environment. For some women, the symptoms are so severe and that they really do need pharmacological intervention, and it's available. We have the research on it, SSRIs, as Dr. Kerr went through, are, the first line treatment. So I think it's really individual based, and if they can get enough control over their symptoms with just, counseling or even brief treatment through the PCP office, wonderful. But yeah, it's going to be person specific.
And that's why I mentioned in the slide, severity of symptom consideration about medication. Not everyone that has PMDD is going to necessarily need to be on a medicine. And like Olivia said, if you can manage it with just kind of that education piece and tracking and kind of knowing this is a period of the month that I need to be a little bit more, just insightful about my behaviors, then I think that can be helpful for some women, that alone.
And then a follow-up question, would you recommend CBT prior to hormone therapy? And if so, how long before initiation of meds?
I don't know that there's any kind of like studies that have really looked at that or kind of set any kind of protocols on it. Again, I think it's going to be in specific. So if you have someone that is just having really debilitating symptoms and again, that goes to this kind of function questions on the tracking. If they're not functioning well, I wouldn't say you have to try cognitive behavioral therapy before we try a medicine, because you're not going to be able to function well in CBT if your symptoms are so severe. So as far as I know, there's not any real studies or guidelines about how long, but I would say it's kind of individual.
Okay, great. I have put up the slide that has the QR code. At this point, I'm not able to see any more questions. Are there any other questions that come from the group? I just pulled up another slide and I'm able to see it. Okay, I don't see any other questions. What I do want to go ahead and share with you is that this presentation today was brought to you by the Child Psychiatry Access Network. I'm going to show one slide on that, and then I'll get you back to your QR code. One moment, please. So the Child Psychiatry Access Network is a network that was created for providers across the state of Texas to support those PCPs that work with children and adolescents and have a need for mental health services to help themselves to continue working with the children. So we have 12 hubs across the state of Texas. UT Health Science Center here in Tyler serves the Northeast Texas region. And by making one simple phone call, you can access consultation with a child psychiatrist. For example, Dr. Kerr is one of our child psychiatrists. We have 2 others. You can also obtain assistance in identifying referral and resources for those children that you serve. For example, if you are looking for a counselor for a child that has PMDD, you could certainly reach out to us and we could help you identify someone that has a skill set that could meet that need, for example, CBT. Our team is here to serve you 8 to 5, Monday through Friday. There's no fee at all for this. This is funded by the state of Texas through the Texas Child Mental Health Care Consortium. Services, again, are available by a simple phone call. You call our team. We'll give you an opportunity to share with us what your need is. If it's a consultation with one of our psychiatrists, great. If you would like to speak to them right away, we can make that happen. Or if you'd like our psychiatrist to call you back between the hours of 8 and 5, we can schedule that as well. And what you will receive from us is additional continuing education. We will be moving forward starting in June with the 1st and 3rd Wednesday of the month at noon. So if you have any questions about CPAN, please do reach out to us. You'll see that cpaninfo@uthct.edu, or you can respond to any of the emails you received from CPAN. Finally, I'm going to put up that QR code slide again. I'm working on 3 screens so that you can have that. And if you have not yet completed your evaluation, please do so. That's what it takes to get your continuing education. I'll leave this on the screen, and I want to thank our presenters today, Dr. Catherine Kerr and soon to be Dr. Olivia Ompierre. And we thank you for your time and your expertise. And thank you for attending as a listener today. And if you have any ideas that you would like to have additional education on, please do share that with us, and have a great day.
Thank you.